Dear friends and colleagues around the world, dear distinguished speakers, welcome to the session 3 of the APASL School of Hepatology e-learning platform, which will be held every last Tuesday of every month at this time. This platform has allowed us to educate young doctors, faculties, and fellows, thanks to the guidance of Professor Chip Sarin, chair of our steering committee of the APASL, and hardworking of Professor Manoj Sharma, who are now, we are now launching the School of Hepatology, and this is the third episode of School of Hepatology by inviting world-renowned hepatologists to speak on the basic knowledge of clinical hepatology in our program. I hope that this program will be beneficial to everyone who attends. Please do not hesitate to ask your questions by typing in the chat box to the speakers, and that will be available after the talk. Next year, the APASL meeting will be held on February 4 to 6, 2021, which is also digital platform. Please visit the website of the APASL 2021. Lastly, I would like to thank all distinguished guest speakers on behalf of the APASL for being the part of our program and all attendees who joined this webinar today. Thank you. I now pass my role to moderators, Professor Rino Gani, past president of the APASL, and Professor Jinmo Yang, president-elect of the APASL. Thank you.
Thank you, Professor Tanwandi. And we will begin the session. For the first session, we have Professor Mohammed Eslam that will talk about the cues for metabolic syndrome in physical examinations. I will read the short curriculum vitae of Professor Mohammed Eslam. He is an associate professor of hepatic medicine at Stored Liver Center in Sydney University. He heads the metabolism and genomic groups at Stored Liver Center and also head of the International Liver Disease Consortium that led to identifications of genetic and epigenetic factors that impact hepatic steatosis, inflammation, and fibrosis. He undertakes basic and clinical research on MFLD, hepatitis C, liver cancer, and hepatic fibrosis. And he's on the editorial board for multiple journals. He had more than 120 publications with more than 4,100 citations, including Lancet, Nature Genetics, Nature Communication, etc. So without further ado, I will give Professor Mohammed Eslam the time to give his lecture. Please, Professor Mohammed Eslam.
Thank you, Mr. Chairman, for the nice introduction, and thanks particularly for APASL for inviting me to give this talk today. So I was asked to talk about clinical clues for metabolic syndrome physical examination. So first of all, as a matter of definition, metabolic syndrome is a constellation of metabolic abnormalities that confer increased risk of both cardiovascular disease and diabetes mellitus. Historically, risk factor for diabetes was first observed in 1920s, and in metabolic syndrome was coined as a term in 1950s, and it started to be better understood into the 70s. And today, the prevalence of metabolic syndrome seems to be high all over the world, including into the Asia-Pacific region. So if you look here on this recent meta-analysis, you can see here into that the prevalence worldwide is ranging between 12% up to 62%, and it's particularly into the Asia-Pacific region. We can see that it's between 12 to 39%, and it's around 26% into South Asia. which means that we are facing a real problem that we should be able to characterize and diagnose probably in clinical settings. And worryingly, if you look here, most of the Asian countries, similar to the rest of the world, are seeing a trajectory increase into the prevalence of metabolic syndrome. Here, for example, in China, in South Korea, in Taiwan, all are seeing increase into the prevalence of the disease. And to date, there are multiple criteria for the diagnosis of the disease. And one of the most famous one is from the International Diabetes Federation. And it depends on the presence of central obesity, defined based on waist circumference using ethnic specific values, with 2 out of 4 factors, including raised triglyceride, reduced HDL cholesterol, raised blood pressure, and raised fasting blood glucose. And there are multiple other criteria for diagnosis of metabolic syndrome. It's up to 10 criteria, and including, for example, this one from the NCB ATP3, and the one from the American Heart Association. And all are mixed between different criteria of the metabolic risk abnormalities, which if it's present, it will qualify the diagnosis of metabolic syndrome. So when we move for the clinical perspective, and to help you to get your head around the medical care of patient metabolic syndrome, this is a suggested simple algorithm for the care of this patient, which is starting by screening or active case finding, then the establishment of diagnosis, then passing to the treatment goal and consideration, and finally the follow-up of this patient. So let's go through these steps together. So starting by the screening or active case finding, it's important to consider that metabolic syndrome needs a high suspicious index because most of your patients will be asymptomatic at the early stages, and it should be considered either by screening or active case finding in overweight or obese subject, in patients with history of hypertension, dyslipidemia, hyperglycemia, and also once you define metabolic syndrome, you should consider screening or active case finding for the related complication of the disease, as we will come to this point later. The second part of the algorithm, which is the establishment of the diagnosis. And here are the simple steps for the evaluation of patients with suspicion of metabolic syndrome, which is started by the medical history, social history about lifestyle pattern, physical examination, clinical and laboratory tests, and finally reviewing your patient for the related complication. So let's go through this point. Starting by medical history, it should be focusing into the three main aspects. So although metabolic syndrome, the diagnosis is mainly based on the physical and laboratory features, it's similar to other diseases. Taking of proper history is important for establishment of the diagnosis of metabolic syndrome. So it includes symptoms which is suggestive of the component of the disorder, like for example, the symptoms suggestive of diabetes, like hunger, thirst, urination, or symptoms suggestive of drug-induced weight gain. A second bit is the symptoms suggesting the risk of the complication, like for example, cardiovascular complication, chest pain, shortness of breath, and finally evaluating for any previous treatment or history can decide about treatment. Moving for the clinical examination, you should assess for the key points of the components of the metabolic syndrome, including increased blood pressure, the anthropometric measurement, and assessment for other criteria might be suggestive of the insulin resistance, like acanthosis nigricans, hirsutism, peripheral neuropathy, and retinopathy. So here, as you can see here, these features can be suggestive into the presence of insulin resistance into physical examination. Moving for the clinical assessment of overweight and obesity, which is a part which is a critical part for the diagnosis of metabolic syndrome. And this is including the estimation of body mass index, which can be calculated simply divided weight into the height square. And patient can be divided into with normal or healthy weight between 18.5 to 25, overweight between 25 to 90.9, and obesity which is over than 30 kilograms. And keep in mind that these cutoffs are different in Asian, whereas overweight is defined as more than 23, and obesity is defined as more than 25. The other important part is the measurement of the waist circumference. So due to the limitation of BMI, which may underestimate or overestimate the body fat distribution in subgroup of subjects, it's important to determine also the adipose tissue, which can be simply measured by the waist circumference by placing a measuring tape in the horizontal plane at the level of the iliac crest without making any pressure on the skin. Importantly to remind that the waist circumference has been shown to be independent risk factor for both type 2 diabetes and cardiovascular disease. So here, for example, in this study into the US Japanese men, intra-abdominal visceral fat was independent risk factor for increasing the risk of diabetes. Similarly, for cardiovascular disease, intra-abdominal visceral fat was in Japanese cohort, independent risk factor for coronary heart disease. And similarly to the BMI, it's important to consider that there is an ethnic cutoff for the determining of the waist circumference. So in European, the elevated one is above 94 for male and above 80 for female. However, in the Asian population, it's above 90 for male and above 80 for female. So moving for the laboratory studies, it includes the standard chemistries to assess for hyperglycemia, renal dysfunction, and lipid disorders. And if your patient has a history of coronary or atherosclerotic diseases, these studies should be extended to including assessments for lipoprotein profile, C-reactive protein, and other measures such as for cardiovascular disease. For imaging studies, it doesn't routinely indicate it into the diagnosis of metabolic syndrome. However, it might be important for the diagnosis of the complication of the syndrome, like cardiovascular disease, so it's including ECG, ultrasonography, the PET study, and the other types of imaging studies. The fourth aspect into the diagnosis, which is a checklist for the complication of metabolic syndrome. And this is, for simplicity, can be divided into three big groups: the cardiometabolic complication, including dyslipidemia, hypertension, prediabetes status, MAFLD, polycystic ovarian disease, diabetes, and cardiovascular disease. And there are biomechanical complications, which including the lung function disorders, neurodegenerative disorders, sleep apnea syndrome, urinary incontinence, and the disability and the gastroesophageal reflux diseases. And there are other types of the complication, which including the male infertility, androgen deficiency, female infertility, gallstone diseases, and psychological disorders, including depression and anxiety, which usually associated with the obesity. So here are simple tips for the three of the key potential complications. First is the MAFLD, which is a metabolic associated fatty liver disease, and it can be diagnosed simply using the APASL algorithm, which is starting by hepatic steatosis in adults with one of three criteria, including overweight or obesity, type 2 diabetes mellitus, and if your patient is lean or normal weight, if it meet two of the metabolic risk abnormalities listed here. Coming for the sleep-related breathing disorder, so if your patient with metabolic syndrome is showing a characters of the sleep disturbance, snoring, possible pausing while sleeping, daytime drowsiness, this patient may get benefit from sleep studying like pulmonography to assess if they have any type of sleep-related breathing disorder as one of the complications of his metabolic abnormalities. Finally, passing to the cardiovascular assessment in your patient with metabolic syndrome. And here, according to the recommendation of the American College of Cardiology, it should be assessed based on the multiple calculators, including the one called ASCVD or the Birmingham risk scores. So you can assess if your patient is low risk, medium risk, or high risk for cardiovascular assessment. The other important aspect when you diagnose patients with metabolic syndrome is that you should also consider for the alternative or additional diagnosis for the component of the metabolic syndrome. Here are three classic examples. For example, in dyslipidemia, you should consider if there is a strong family history that it may be inherited dyslipidemia. For hypertension, please don't forget the secondary causes of hypertension like renovascular disorders, renal aldosterone metabolism, and obstructive sleep apnea syndrome. For hyperglycemia, apart from diabetes, consider the other causes of disturbance like thyroid dysfunction, endocrinopathies, photochromocytoma. So back to our algorithm. So after establishment of the diagnosis, let's move for the treatment goal and the consideration. And it's mainly focused onto the lifestyle intervention. But because metabolic syndrome is a multi-systemic disease, the key aspect on the management is the integrated multidisciplinary approach, which can include hepatologist, endocrinologist, nutritionist, and psychologist, clinical pharmacist, and physical therapist. And cardiovascular reduction is the main goal of treatment, including the reduction of dyslipidemia, hypertension, smoking cessation, and antiplatelet therapy. Screening and treatment of the other comorbid conditions is also of critical importance. So lifestyle intervention is the core of management. You should manage the individual component like diabetes using anti-diabetic drugs, decreasing cardiovascular risk, treatment of advanced liver disease. And here are some tips for the key lifestyle changes messages for your patient. So it depends on to decrease intake of trans fat and saturated fat. So saturated fat should be less than 10% of the energy intake. Omega-6 fatty acid should be between 5 to 8% of the energy. Omega-3 fatty acid between 1 to 2% of energy. Fish intake should be between 1 to 2 servings a week. Reduce salt intake by the third. Eat at least 7 servings a week of fruits and vegetables. The take of whole grain breads, cereals, about 20 gram dietary fibers per day. Maintain body weight within normal range as possible. Minimize alcohol intake as much as you can. And physical activity at least 30 minutes a day. So in conclusion, metabolic syndrome is a prevalent worldwide and particularly in Asia-Pacific region. It's a constellation of metabolic abnormalities that increase the risk of both cardiovascular complication and diabetes. And clinically, it needs a high suspicious index for active case finding and screening. It's crucial to consider for medical complication related to metabolic syndrome once the diagnosis is established. Lifestyle changes are the key for reducing metabolic syndrome complication. And please consider that this is a lifestyle disease, so lifetime commitment and follow-up of your patient is a key for the treatment. And thanks for your attention.
Thank you very much, Professor Mohammed Eslam, for your very comprehensive lecture for the cues for metabolic syndrome in physical examinations. We will have a discussion after this three lecture, and we are going to have the second lecture. The second lecture will be presented by Professor Valentin Fuhrmann. I'm very sorry for the pronunciations. Professor Fuhrmann studied medicine at University of Vienna until he also have his gastroenterology degrees, and he published more than 100 articles on nutrition and also in liver. He's the deputy chair of section of liver failure, German Society of Intensive Care, and director of Department of Medicine in Evangelisches Klinikum Niederrhein, Germany. So without further ado, please, Professor Fuhrmann, present your lecture on pulmonary science in liver disease.
Yeah, hello from Germany. My name is Valentin Fuhrmann. I'm very happy to contribute to this interesting meeting, and my topic is pulmonary science and liver disease. I will talk about causes of respiratory insufficiency. Thereafter, I will focus on clinical presentation and on the examination tests in patients with liver diseases and respiratory insufficiency. So respiratory insufficiency is a frequent finding in patients with liver disease. More than 50% of patients with cirrhosis, for instance, have an increased AAPO2, and more than 30% of patients undergoing evaluation of liver transplantation suffer from shortness of breath. There's a huge variety of causes of respiratory insufficiency in liver disease. This can be divided on primary pulmonary causes, cardiac causes, and extrathoracic causes. The pulmonary causes can be subdivided in diseases or alterations of the pulmonary vasculature, like hepatopulmonary syndrome that is observed in 20 to 30% of patients with cirrhosis, or portopulmonary hypertension that can be observed in up to 5% of patients with end-stage liver disease. On the other hand, you can find alteration of the lung parenchyma, like chronic alterations, COPD, pneumonitis as in autoimmune diseases, pneumonia or aspiration as it may be observed in patients with hepatic encephalopathy, and others. And furthermore, you can have alterations following alteration of the pleura and diaphragma that mainly contribute to restrictive lung diseases that are observed in up to 20% of patients with chronic liver diseases. This can be, on the one hand, pleural effusion, like hepatic hydrothorax that is observed in up to 5%. On the other hand, also ascites, you can contribute to extrathoracic causes I mentioned also here, because I think it's one of the main causes of respiratory insufficiency in patients with end-stage liver disease. Furthermore, cardiac causes can be divided into several alterations of the heart, like cardiomyopathy, acute myocardial infarction, rhythmogenic or valvular heart diseases, and others. And extrathoracic causes, as mentioned previously, ascites, but also metabolic alterations like metabolic acidosis that may contribute also to hyperventilation and respiratory insufficiency, anemia, and others. So basically, respiratory insufficiency is frequently, but does it also have clinical impact? We assessed a cohort of patients with liver cirrhosis, and you can see here several subgroups, group 1 to 5, and one group has dramatically increased one-year mortality rates. And this group is the group of patients with PO2 levels below 60 millimeters of mercury. So this is a division of liver diseases according to the oxygenation impairment, and severe oxygenation impairment independently of the etiology contributes to dramatically increased mortality rates. This analysis was also corrected by severity of liver diseases is an independent predictor of increased mortality. Going back to the clinics. What are clinical characteristics of patients with respiratory insufficiency? On the one hand, dyspnea is the leading symptom in several etiologies of respiratory insufficiency. For instance, hepatopulmonary syndrome, but it's not specific for HBS. Dyspnea may also be present in different kinds of respiratory insufficiency, like pneumonia, COPD, or even ascites. You have to assess the medical history. Are there pre-known pulmonary diseases? Are there pre-known cardiovascular diseases, and so on? And you have to assess the current medical condition of the patient. Is there any infection present? What about the fluid state? Is there a lot of fluid retention? Is there acute kidney injury, and so on? During physical examination, you assess presence of cyanosis or digital clubbing, as illustrated here on the cartoon on the right side. The digital clubbing is a typical sign of chronic hypoxemia. You assess the presence of telangiectasia that may be present in advanced liver disease and also present in patients with hepatopulmonary syndrome. And then you can assess the presence of platypnea. Platypnea means the worsening of dyspnea by moving from the supine position to the upright position, and this is quite frequently found in patients with hepatopulmonary syndrome. That is not a specific alteration for hepatopulmonary syndrome, as it can be also observed in other cardiovascular diseases and pulmonary diseases, like, for instance, cardiac septum defects and so on. But it may be an hint for presence of hepatopulmonary syndrome. On the other hand, you have also the term autodeoxia. That means quite the same, but not by the clinical assessment, but by the assessment of PaO2. If you move from the supine to the upright position, the PaO2 decreases by more than 5% or more than 4 millimeters of mercury. So this are the two terms that you should consider in patients with hepatopulmonary syndrome, platypnea, and autodeoxia. On the other hand, you can observe decreased diffusion capacity of carbon monoxide in pulmonary function testing in patients with hepatopulmonary syndrome. I will talk about it later. And you can observe a significant sleep time oxygenation desaturation in patients with, for instance, hepatopulmonary syndrome. Interestingly, HBS is less common in smokers. Chest imaging. I think one of the important issues in every patient with respiratory insufficiency is imaging techniques, and chest imaging usually use X-ray assessment. Here you can see a normal chest X-ray, but you can find alterations like pleural effusion here on the right side, typical for hepatic hydrothorax, for instance, or even pneumothorax can also be present in patients with liver diseases. If you are not sure what the problem is, you can perform also in CT scan. Here you can see a pleural effusion also on the right side, as it can be found in hepatic hydrothorax, for instance, or otherwise also have a look on the pulmonary vasculature, because on the one hand you can find alterations like in hepatopulmonary syndrome. Otherwise, you can also find alterations like thrombi and in this case pulmonary embolism. You should be aware that the risk for thrombosis and pulmonary embolism is increased up to twofold in patients with liver disease compared to healthy people. Other opportunities of assessments: how to quantify respiratory insufficiency. Frequently, it's recommended that pulse oximetry should be used as a screening tool, and if the saturation is below 96%, you should proceed to other assessing tools. However, recently there was a large American study that assessed the value of pulse oximetry for detection of hepatopulmonary syndrome in patients validated for liver transplantation. They observed a very low sensitivity and do not recommend pulse oximetry as screening tool for hepatopulmonary syndrome. Which kind of alternatives do you have? On the one hand, respiratory function tests. Respiratory function tests are not specific and maybe less helpful for diagnosis in patients with liver diseases. However, they usually are necessary to assess the gas exchange abnormalities and may support you for establishing the differential diagnosis of dyspnea. Patients with liver diseases have usually normal lung volumes in the absence of any other respiratory disease. However, recent studies demonstrated that about 20% of patients may present a reduction of forced vital capacity as well as FEV1 as a consequence mainly of ascites or co-occurrence of undiagnosed COPD. And as mentioned previously, the diffusion capacity for carbon monoxide is frequently reduced in patients with advanced stages of hepatopulmonary syndrome. This is a consequence of the reduction of gas exchange due to increase in the distance between the alveolus and the capillary, due to vascular dilatation and due to increase of the capillary wall thickness. I think one of the cornerstones of assessing respiratory insufficiency in patients with chronic liver disease is the arterial blood gas analysis. Here you can see an arterial blood gas analysis with severe decreased PaO2 and slightly decreased PaCO2 as a consequence of hyperventilation that can be observed quite frequently in patients with chronic liver disease. Oxygenation is also used as an staging and grading criterion, for instance, for hepatopulmonary syndrome, which is one of the main causes of chronic respiratory insufficiency in patients with chronic liver diseases. Increased APO2, or the grading can be performed according to the PaO2 levels above 80, between 80 and 60, below 60. And these are important cutoffs, not only for staging of HBS, but also for clinical consequences. Usually it's recommended to initiate long-term oxygen therapy if PaO2 levels are below 60 millimeters of mercury in patients with chronic hypoxemia and comorbidities. This cartoon illustrates the presence of gas exchange abnormalities in patients with chronic liver diseases, with special focus on hepatopulmonary syndrome. On the x-axis you can see the PaO2 levels, on the y-axis you can see the ADO2 levels, and the dark spots are positive, patients positive for HBS. The prevalence is 32%. And you can see that more than 10% in this cohort of patients with chronic liver disease have an PaO2 below 60 millimeters of mercury. So this is not a rare finding. It's frequently underdiagnosed, and you should be aware to screen patients with insufficiency, respiratory insufficiency, also for hypoxemia by arterial blood gas analysis, because up to 10% may suffer from severe hypoxemia. Other techniques that are important in assessment respiratory insufficiency in patients with chronic liver diseases, I think echocardiography is one important issue. You can assess the ejection fraction, you can screen for presence of valvular heart diseases and other cardiac diseases. You can assess the presence of pulmonary artery hypertension by performing the simplified Bernoulli equation. It means 4 times the critical speed regurgitation velocity plus central venous pressure. That is a non-invasive assessment and screening tool for the systolic pulmonary artery pressure. I will talk on this field later on. On the other hand, you can also perform advanced echocardiography by using a transthoracic contrast-enhanced echocardiography. That's a quite simple screening tool for hepatopulmonary syndrome to assess interpulmonary vasodilatation. You apply agitated saline, for instance, alternatively hydroxyethyl starch or gelatin or albumin, and then you can see here the appearance of the contrast agent in the right atrium. And after a time of 3 to 6 heartbeats, also appearance in the left atrium. And if you observe this, consequence, that's a typical alteration that is observed in patients with intrapulmonary vasodilatation. In contrast, if you have intracardiac shunting, you see an immediate appearance of the agitated contrast agent in the left atrium after application after appearance of the contrast agent in the right atrium. So this is the real life data. This is the transesophageal view. Right atrium, right ventricle, left atrium, left ventricle, and here that's what it looks like, appearance in the left, and after 3 to 6 heartbeats you see the appearance in the left ventricle of the contrast agent. That's a typical sign of intrapulmonary vasodilatation, as it is observed frequently in hepatopulmonary syndrome. Okay, I mentioned previously the pulmonary artery pressure for detection of portopulmonary hypertension, for instance. What are usual used cutoffs? If you observe a systolic pulmonary artery pressure above 40 to 50, you proceed to invasive assessment of pulmonary artery pressure by pulmonary artery catheterization. One study observed the best cutoff 38 millimeters of mercury, others observed slightly higher ones. So usually between 40 to 50 millimeters of mercury, systolic pulmonary artery pressure in transthoracic echocardiography, you should proceed to pulmonary artery catheterization for further assessment. The pulmonary vascular resistance is frequently altered in patients with chronic liver disease. On the one hand, you can observe decreased pulmonary vascular resistance that is frequently observed in hepatopulmonary syndrome with intrapulmonary vasodilatation that is observed more frequently in up to 30% of patients. On the other hand, you can also find increased pulmonary vascular resistance that is observed in 1 to 5, some studies reported even higher percentage of increased pulmonary vascular resistance in patients with portal hypertension. So there's a huge variety of alterations in pulmonary vascular resistance, and several pathophysiological alteration can contribute to this. This is an already slightly older graph, but this illustrates one important aspect that was observed mainly in experimental models. So we have several alterations of bile acids, cholangiocyte proliferation, inflammation, and nitric oxide production, carbon monoxide, angiogenesis, and so on. One aspect is, for instance, endothelin 1. Endothelin 1 is known mainly as a vasoconstrictor, but it depends on the kind of receptor where it binds, what effect it has. For instance, in a model of hepatopulmonary syndrome that is known for vasodilatation, endothelin 1 is increased and binds to endothelin B receptors in the pulmonary vasculature, and this contributes to increased nitric oxide and carbon monoxide production and contributes to vasodilatation and HPS. On the other hand, in patients with portopulmonary hypertension, you have in severe pulmonary vasoconstriction and remodeling. These patients also have increased endothelin 1 levels. However, endothelin 1 mainly binds to an increased expression of endothelin A, not B, A receptors, and this contributes to pulmonary vasoconstriction. So there's a lot of pathophysiological alterations that can be treated maybe by one drug, an endothelin receptor antagonist. However, this is not part of my talk. So this slide summarizes the clinical distinctions between the main pulmonary vascular alterations that are observed in patients with chronic liver diseases, hepatopulmonary syndrome, and portopulmonary hypertension. Both of these diseases have a genetic predisposition. Screening is advised. Always consider pulmonary function and arterial blood gas analysis. Always consider echocardiography, and always consider also chest imaging techniques. Lung biopsies are not needed for diagnosis. You need arterial blood gas analysis mainly for HPS, right heart catheterization mainly for portopulmonary hypertension. Severe hypoxemia may be quite frequently in HPS and is rarely observed in portopulmonary hypertension. Both diseases are associated with an impaired long-term survival. Indication for liver transplantation, HPS, yes. Portopulmonary hypertension, at least mild stages, otherwise no. And the resolution of liver transplantation can be observed in both diseases and is very well described in patients with hepatopulmonary syndrome. So I come to my conclusion. Respiratory insufficiency is a common problem in patients with liver diseases and is associated with increased mortality rates. There is a huge variety of potential causes of respiratory insufficiency. Main causes are alterations of the pulmonary vasculature, lung parenchyma, and disease of pleura and diaphragma, including ascites. And an early establishment of the correct diagnosis is of central importance because you have only the opportunity to initiate adequate treatment after an adequate early diagnosis. So thank you very much for your attention.
Oh, thank you very much, Professor Fuhrmann, Valentin Fuhrmann, for very informative lecture. And
yes,
for
I'm doing it.
The third lecture, I will convey to Professor Yang for Professor Yang.
So ladies and gentlemen, now we started the last topic of today's APASL School webinar session. It's an honor to me to invite Professor Adrian Reuben. Professor Adrian Reuben is a professor of Medical University of South Carolina at Charleston, USA. His concern is acute liver failure, coagulation in liver disease, and non-invasive investigation of disease and drug hepatotoxicity. He published over 170 peer-reviewed articles and so on. And now He is a chair of hepatotoxicity special interest group of ASLD. Today, his topic is how to do a comprehensive physical examination of the liver disease patients. Professor Reuben, please.
Hello. Okay, wonderful. I have to say good afternoon to friends and colleagues in Asia and Pacific Rim. I wish I was with you and not on a Zoom, but maybe next year I can come back to India and Japan and China, where I've visited several times. I'm very honored that the leadership of APASL should trust me to give this important lecture to very formative minds. But the pleasure for me is during my career, the joy I would get from teaching at the bedside and clinically medical students and house officers, and I don't know if you have registrars where you are, and fellows and so on, is really a great pleasure for me. Now, I have actually published a couple of review articles on this topic, which you see on the screen now. And if you would like, anyone would like a copy of the lecture or of these articles or other things, please contact me. You see my email address there, and I would be very pleased to send it to you. Okay, now, when I was a medical student, I was taught there were 4 principles to the physical examination. Look, first of all, listen next, then percuss, and palpate least of all was what we were taught. But we'll see how we can exemplify that in today's talk. So overall, the appearance of the patient, their conscious level, whether they're awake, whether they're cognitive, the posture, the comfort level, tremors, including the classic flapping asterixis, and the twitching or jerking that most people do not realize, oh dear, it's racing on, I don't want it to do that. That people don't realize is part of asterixis. And now there's a 5th component, fetor, smelling the breath, is awful mousy smell of the patient with liver disease. So we can add olfaction to the list of principles. We look in the eyes for the yellowness, the skin, the mucous membranes, and indeed any other body fluid, urine, or even CSF, are looking for the yellow. Cyanosis may indicate that we have a degree of hypoxemia associated with those lung conditions that were just described. And I think that oximetry now is part of the physical examination, because if it's below 96%, then we have some oxygen transfer problems. The nails are very informative, especially finger clubbing, and there are other nail and skin abnormalities. Gynecomastia is a manifestation of cirrhosis, especially in males, especially those who have alcoholic testicular atrophy and may have a further imbalance of the estrogen testosterone system. We're learning more and more that the nutritional state is important, especially muscle loss or sarcopenia, which influences the outcome of the cirrhosis and the outcome of operations, including transplantation. And then last in this category, we need to look at the heart, especially jugular venous pressure, if there are murmurs and so on, which may be manifestations of a cirrhotic cardiomyopathy. Now, below the red line, we have the examination of the abdomen. Look at the veins, and I'll discuss that. What does the umbilicus look like? Very important. Other hernias and other skin lesions. I would tell you what I think is the best way to examine and categorize ascites. We look at the liver size. There's the left lobe palpable from hypertrophy. Tenderness, is the liver pulsatile associated with heart problems like a mitral valve regurgitation, and the nature of the tenderness, the softness of the liver, are there nodules? Is the spleen palpable? I don't know why it keeps moving on. Is the spleen palpable, and are there other abdominal masses? Now, the word abdomen is rather interesting because it comes from the Latin abdere, meaning to hide, and indeed the liver is a hidden organ. It's actually in the thorax, even though it's in the abdomen, high in the right upper quadrant beneath the right hemidiaphragm, And I believe that the main function that the liver has is to keep the heart from falling down. Normal liver, spleen, and kidneys should be impalpable, except in a very thin person, an emaciated person, or those who have emphysema, where the hyperinflated chest pushes down the diaphragm. The word belly comes from the Old English word belge, meaning a protuberance, a bag, a distension, or a swelling. And of course, that's typical of patients with advanced liver disease. Now, some people think that jaundice and icterus are different descriptions. Icterus is yellow in the eyes and jaundice is yellow in the body. That is not true. Jaundice comes from the French and the Latin, meaning yellow, and icterus comes from the Greek. So just plain yellow would actually do. Now, some people think they can distinguish the lemon yellow of hemolysis from the orange yellow of hepatitis, from the green yellow of cholestasis. I'm not sure that that is that easy. However, with some of these lesions, cholestasis, for example, you have associated conditions such as the fatty deposits around the eyes, or xanthelasma, which you can see were recognized by Addison and Gull 170 years ago. When these fatty deposits occur on pressure points like the elbows and the knee, as you see in the Addison-Gull report, these are manifestations of chronic cholestasis. Now, another one is the result of the pruritus that accompanies cholestasis. And here you can see a woman who could scratch the top of her back and the bottom of her back, but not the middle. And so this area of spared hyperpigmentation, it's inside the circle in a butterfly distribution, was recognized by the famous hepatologist Telfer Reynolds in '73, and very characteristic of the itching that occurs with chronic cholestasis. Now, the face has many messages. This is a subtle one. This is parotid swelling in a patient with alcoholic liver disease, but it's very real when you detect it, and it's worthwhile, may give a clue to their alcoholism. In old-fashioned paper money, there were little fine threads that were part of the security, and that gives the name to these fine venules you see on the surface of the skin, so-called paper money skin. Here are other telangiectasia. These ones are occurring in the supraclavicular notch, so-called mat telangiectasia. And of course, we have the famous spider nevus that has around about 6 or more AKA, also known as, and you can see this very large spider nevus on the arm of one of my patients. Now, the spider nevus is actually a dilated spiral arteriole. You can see on this man's forehead, and here is the enlargement, where the blood is flowing through at systolic pressure. It's a arterial pressure. It's not a venous abnormality. And so if you can press on this lesion with a transparent object like this magnifying glass, you can actually blanch the spider nevus out of existence when you exceed systolic blood pressure. So spider nevi will disappear when the liver disease resolves. Here you can see a man with 2 spider nevi on his head, and when he undergoes a successful transplant, the spider nevi disappear. Now, rather grotesquely, they also disappear when the patient dies, because the heart is no longer pumping, so the blood is not flowing through the lesions at systolic pressure, and they disappear actually post-mortem. Sometimes patients have vascular abnormalities which are not related to the cirrhosis or the liver disease as such. This patient had cirrhosis, but the cirrhosis was due to hepatitis C, and what you're seeing here is a cryoglobulinemic vasculitis in association with that viral infection. Spiders are usually found on the upper body, typically above the nipple line. So you see them in the face, the neck, the hands, the upper chest, but they can occur anywhere, including the colon. Here at colonoscopy, you can see over here, if I can point to it, a spider nevus. Here is another one, and here is a very beautiful one seen in the stomach at upper endoscopy. Finger clubbing is a very interesting topic, because in cirrhosis, it's very common. But remember that you also see finger clubbing in lung diseases, cancer, lung abscess, fibrotic lung disease. in the abdomen in inflammatory bowel disease, particularly Crohn's disease, in cyanotic congenital heart disease, and in heart valve infection, subacute bacterial endocarditis. And here we see idiopathic clubbing, which is a hereditary disorder the patient inherits from the family, there being no liver disease as such. Pseudoclubbing occurs when the bones of the distal phalanges are eroded and the phalanges collapse due to, for example, hyperparathyroidism, and so we see the lesion of pseudoclubbing. Now, the next pictures are those of Dupuytren contracture, more typical on the right upper hand where the ring finger is contracted, but also you see the small fingers also being contracted. Many people think that this is related to alcoholism and alcoholic liver disease. It is not. It has two obvious causes. The first is a genetic defect inherited from the Vikings. In fact, there's a clan in Scotland of famous bagpipe players who have to give up their profession at the age of about 40 because their Dupuytren prevents them from playing their bagpipes. But it's also common in people who use strong vibrating instruments like a jackhammer. Now, Dupuytren and clubbing can actually occur in the feet. Here you see clubbing in the feet of a patient of mine who also had contractions of the solar, the fascia of the palms. And this is associated in a rather bizarre way with the Peyronie deformity, another fibrotic abnormality, but this time of the penis described several hundred years ago. This picture of palmar erythema in the hands is not as vivid as I would like it, but I think you can see that there's redness of the palmar, of the hypothena, the thena eminence, and even of the palmar surfaces of the distal phalanges of the fingers. And in fact, sometimes it even encroaches round onto the other side. But there are more changes that occur in the hands in patients with cirrhosis. We've mentioned palmar erythema and finger clubbing. You see that on the left. Terry's nails is a total whitening of the nail except for some peripheral pigmentation at the tips, which is the arrow is showing. And this is quite common in patients with advanced liver disease, but other chronic debilitating conditions, especially if there's hypoalbuminemia. Now, Merck's nails and Bow's lines are nothing to do with liver disease, but these are interruptions in the growth of the nail along its development during times of severe illnesses, as you see. Gynecomastia, I mentioned, is visible in men. Obviously, this particular patient had cirrhosis, but was not an alcoholic, and in fact, his gynecomastia was related to spironolactone use for ascites and edema, and spironolactone is actually structurally related to the estrogen. So that is another, what we call not a side effect of the drug, but really a front effect. I mentioned already the importance of malnutrition and especially muscle wasting. Here you can see in the patient's face on the left, the temporal wasting that is so typical, but the patient's back may in fact be much more revealing than the front. The arrow shows you the winging of the scapula where the loss of muscle or sarcopenia, Greek for poverty of flesh, is showing most. Interestingly enough, this patient is the one whose spider nevus, the large one on his upper arm, was the one that I showed you at the very beginning. Now let's turn to ascites. This is weeping of extracellular fluid from the surface of the liver through the capsule when sinusoidal pressure from portal hypertension is above 10 to 12 millimeters of mercury. You can see on the left the typical bulging abdomen, the beginning of the eversion of the umbilicus, which you can see on the right, and very, very difficult to distinguish superficial veins that are actually coursing upwards from the below the liver, bypassing the obstructed, if you like, hypertensive liver to enter the superior vena cava. Now, the importance of this umbilical hernia, which incidentally was recognized by the Mayan civilization many hundreds of years ago, is that if clothes or other causes a rub on the umbilical surface, then it can cause soreness, inflammation, erosion, and eventually it can actually burst through, as we see in the aftermath of this so-called flood syndrome or rupture of the umbilicus in a patient with massive ascites. People think that it's called the flood syndrome because the ascites floods out, as indeed it does. But actually, it's an eponym after Frank Flood, who described this entity of spontaneous perforation of the umbilicus in the New England Journal about 60 years ago. The flood syndrome is a medical emergency. Immediately, it should be dressed, antibiotics given, and operation should be considered within 24 hours. Now, there are other, there are other umbilical and paraumbilical lesions. At the top, we see the Cullen sign of bleeding within the abdomen that perfuses into around the umbilicus, or it could be any other pigmented cause of ascites. The gray Turner sign shown in the middle is due to hemorrhagic pancreatitis, where the blood perfuses through into the flank. And the right-hand image is actually Cullen sign in both the umbilicus, not quite so visible, but the paraumbilical region. The bottom right is the famous Sister Mary Joseph Dempsey sign, which is a metastasis of intra-abdominal malignancy, in this case pancreatic cancer, to the umbilicus. And this was pointed out to William Mayo, one of the two founding brothers of the Mayo Clinic, many, many years ago. She was a nurse at Mayo and pointed out this lesion to the great William Mayo. And on the right, you can see that the umbilicus is also the target of many systemic abnormalities. In this case, a psoriatic plaque is seen there. Now, we mentioned already umbilical hernia, but there are other hernias that occur in the abdominal wall. You see them all displayed here. The importance of these in a patient with cirrhosis who has ascites is that the repair of the hernia is problematic. The current wisdom is that we should treat the ascites as well as we can with drainage, with diuretics, even with tips if that is necessary, and do an elective repair of the hernia before an emergency occurs of incarceration or strangulation. But a word of caution here: if you drain the ascitic fluid too rapidly, the sudden drop in intra-abdominal pressure will lead to closure of the mouth of the hernia around the hernia base itself, causing strangulation as a result of treatment. So when you drain someone with a hernia and massive ascites, do it slowly. You can still do a total abdominal paracentesis, but it must be done slowly so that the pressure drops slowly. And this even applies, there have been cases of patients who've had tips placed for intractable ascites who develop umbilical strangulation, hernia strangulation in the aftermath of the ascites resolution. Now, I already mentioned these abdominal wall veins, which occur because the blood from below cannot permeate through the cirrhotic liver, and therefore they course in paraumbilical veins across the costal margin into the superior vena cava. And it's important in the way that we've been taught to put a finger, expel the blood, and see which way the veins are flowing. Now, this is quite distinct from what I'm showing you here. I call it the legendary caput medusa. Why legendary? Because it's rarely seen. I've probably seen one or two of these in the whole of my career. Now here, the blood flows in the collaterals, radiating away from the umbilicus, away from the recanalized umbilical vein that is carrying blood out of the liver into veins, collaterals, which course upwards into the superior vena cava and downwards into the inferior vena cava. A more serious example is shown on the right. I would recommend that we reserve the term varices for mucosal collaterals, one that can bleed, although strictly they're still called varicosities or varices, even the ones we're seeing here. Just a nice distinction that I have been accustomed to using. Now you can see many other tortuous varicosities. Here is an awful looking appearance of chronic portal schistosomiasis, which is the very, very high form of extrahepatic portal hypertension. But I think there must also be some inferior vena cava obstruction for the veins to get so large and course upwards to cross into the superior vena cava. And here's probably the worst manifestation, the Budd-Chiari syndrome, hepatic venous thrombosis, where the abdominal wall collaterals are bypassing the whole of the liver, not because the portal vein is obstructed, not because the liver is cirrhotic, but because there is no outlet from the liver through the obstructed hepatic veins. And of course, this is a bad combination because as a result of hepatic venous congestion, even if cirrhosis hasn't occurred, you can have massive ascites as shown in this unfortunate patient. Now, I mentioned that varices can occur anywhere in the body, in the esophagus, in the stomach, in the colon, and so on. But here they are visible because this is a patient who's undergone colectomy and has an ileostomy, and the varices are, they're truly varices, are forming in the stoma itself. This is a very difficult situation because when these varices bleed, direct pressure is very difficult to apply, and so the patient must undergo TIPS placement or transplantation to cure this bleeding diathesis. Now let's turn to ascites. First of all, the best way to detect ascites in the first place is with flank dullness. Here the patient is lying flat, and if you percuss across the surface of the abdomen from left to right, you will see you encounter a dull area of fluid where the ascites has gravitated to the right paracolic gutter. You meet a resonant area in the middle, and then you cross another dull area on the left, the same reason. If you turn the patient onto their side, left or right, and do the same percussion survey across the abdomen, now all of the fluid has gravitated below and is obviously at a much higher level, and the resonant area due to bowel floating above it is above that. But remember, you can see shifting dullness with patients who have severe diarrhea, who have intestinal obstruction, and funnily enough, you can even see it in patients with massive obesity, even though the fat is confined to the adipocytes, is within cells. Nonetheless, it's fluid at body temperature and can even mimic shifting dullness. Some people recommend two other ways of assessing ascites. One is a so-called fluid wave. This is very difficult to elicit. It requires 3 hands, which most hepatologists do not have. And the truth is that if the ascites is massive enough to get a positive fluid wave, when you can recruit another hand, you could actually see that they have massive ascites. You don't need to do a fluid wave. The puddle sign is something I've never elicited, where the patient is put on all fours and the percussion of their abdomen then takes place where the fluid has gravitated to the center of the abdomen. This is really an embarrassment for the patient, and I do not think adds anything to our examination. So I think fluid waves are for fishes and puddle signs are for dogs, but this is not something that we should submit our patients to. Now we can see lesions all over the abdominal wall. People think that these red spots, the cherry angiometer of Campbell de Morgan, who was a surgeon of the 19th century, are actually somehow related to liver disease, portal hypertension. They are not. They're very, very common. The differential you can see on the right, anything from malignant melanomas. They could indeed be spider nevi, but remember those are mostly in the upper abdomen, pyogenic granulomas, Kaposid insect bites, and so forth. And so these all must be distinguished. Now, what is the best way to actually palpate an abdomen? On the left side, you can see a method that I personally do not like of palpating with the right hand as the feeling hand and pushing with the left hand as the pressure hand. I don't enjoy, and I've never found that. It looks very professional. The patient might be very impressed, but I don't find it very useful. I think it much better to do the one-handed approach where you use the edge of the blade of the hand and gently and slowly press deeper and deeper so that you don't obliterate the feeling in your hand, but you can actually detect the organ underneath. On the other hand, the two-handed approach is definitely necessary for the palpation of kidneys and spleen, so-called bimanual palpation, where the organ in question, whether it's the spleen or the kidney, which is a posterior abdominal structure. Remember, the spleen is posteriorly between the 9th and the 11th ribs, is pulled forward by the left hand so that the right hand can actually feel it, and it's added to if you ask the patient to take a breath at that time. So that's bimanual palpation, which is often overlooked. Now here we finally can palpate the abdomen. What are we looking for? We want the span of the liver. We want the consistency. Is it hard? Is it nodular? Is it regular? Is the left lobe palpable? You see the two arrows below the right-hand one showing the left lobe, which is enlarged because of hypertrophy in patients with cirrhosis. Is it pulsatile in association, say, with mitral reflux? Is it tender? Is the spleen palpable, how big it is? One caution, when you want to elicit the so-called hepatojugular reflux, which really can be done by increasing the pressure in the abdomen by pressing anywhere to increase venous return from the inferior vena cava to compromise the flow into the heart from the superior vena cava, do not press on the liver. Remember, those patients who are likely to have a positive sign are those who have a congested liver, and therefore they're exactly the patients who are going to elicit tenderness when you press, so you press anywhere else except the liver. So hepatojugular reflux is really a misnomer. Now, after palpating from below, we know that the liver, when it enlarges in a upper quadrant to left lower quadrant direction. And one thing is very important, you can feel the edge of the liver below, the lower edge coming from above, but the upper edge, of course, is in the lungs, and you will not be able to palpate. This is one way to distinguish the liver from another intra-abdominal organ where you may be able to get to the upper border. So then you percuss from below, from bowel resonance to the liver edge, and from above, from lung resonance to the liver edge, and between them you have the span. You can also ask the patient to breathe, and if you feel that the liver dullness is moving, then you know that the right diaphragm is working. And after that, we proceed to palpate the spleen in the bimanual method that I have shown you earlier. So this is a quick, what we used to call a Cook's tour through the physical examination of the patient with potential liver disease. I hope that it's been clear. And again, I would emphasize that if anybody would like a copy of the lecture itself with all the figures that I have given, or those two reviews that I have published about the physical examination, I would be very pleased to send them, and I'd be very pleased to answer questions. Thank you very much for your attention and for the invitation to give this talk. Thank you.
Professor Reuben, thank you for the good lecture today, and many good photos that are very helpful for the physical examination in liver disease. Now we have a Q&A time. So first question is, sir, what is use of aspirin and atorvastatin in treatment of metabolic syndrome, and for how long? So Professor Eslam, please.
Yes, sorry, can you say that question again? Yeah, I just didn't.
So use of aspirin and atorvastatin in the treatment of metabolic syndrome, and how long time use?
Yeah, that's a really good question. I think as we were talking that metabolic syndrome, it's just a concentration of different metabolic abnormalities by itself. So the decision of using the statin or antiplatelets, it depending on to the indication of the underlying disorder. Like for the dyslipidemia itself, according to the guideline for dyslipidemia, for cardiovascular risk by itself. So metabolic syndrome, it's not an indication, but it depends on to the underlying components.
And my question is, how about aspirin? My knowledge is the aspirin use is only a previous history of CV and disease.
Exactly. Yes.
And
yes.
And atorvastatin use nowadays, some report shows long-term use of atorvastatin is low prevalence of hepatocellular carcinoma. So, what about you? It's okay.
Yes,
yeah. So, long-term use of atorvastatin is better than better for low prevalence of hepatocellular carcinoma. Yeah.
Yes.
And second question is ultrasound has very low sensitivity to distinguish normal and grade 1 fatty liver. You recommend on ultrasound as a screening test for fluoro?
Okay. So that's another good question. Actually, the screening for muffled is an area of controversial, and it's mainly because there is like lack of confidence on the cost effectiveness for the screening. And there is a recent meta-analysis just published in Gastroenterology a couple of months ago suggested that screening might be actually a cost effective in a particular subgroup. And for most of the organizations, they are suggesting more than wide screening, active case finding into the high risk population because it would be more cost effective. Secondly, as regarding to the tool, I think would be different from one center to another according to the available resources and the access for the different diagnostic modalities. So in some centers, ultrasonography are more available, others they have CAP, others they just have blood biomarkers. So it would be mainly depend according to the physician and the available resources in his center.
Thank you. How do you screen for NAFLD in the primary care clinic? Is the same question. So
I think it's the same point.
Yeah. So next question is to Professor Fuhrmann. Is the mechanism for finger clubbing in cirrhosis only related to hypoxemia?
I think it's the main issue. Yeah, it's not specific for hepatopulmonary syndrome. Can be observed in any kind of chronic hypoxemia and chronic pulmonary diseases, in cardiovascular diseases, and even other diseases. Chronic hypoxemia is the main cause, and this may contribute to the increase of the vascular capillary bed in the fingers, and this may contribute to contributes to digital clubbing. So hypoxemia is the main trigger. Yeah.
And my question is, finger clubbing is only in alcoholic-induced liver cirrhosis, not viral-induced.
No, I don't think so. Any advanced cirrhosis will have finger clubbing. It's a consequence of platelet, and the exact pathogenesis is really not clear, but I don't believe it's specifically related to alcoholic liver disease. I may be wrong, but that's been my impression over the years.
I agree.
Okay, the next question is features on hypogonadism in women. Is there some hypogonadism in women? So is features of hypogonadism in women.
Oh yes, well, in women, of course, this imbalance of estrogen versus estrogen will lead to menstrual abnormalities and other manifestations, including maybe a component in the sarcopenia. There has been some suggestion that testosterone injection or tablets can actually help the sarcopenia. Gynecomastia obviously would be difficult to detect, but if anything, there is breast atrophy in women with advanced liver disease rather than gynecomastia. So it's a question of the balance. And in the male patient, the balance is in the estrogen direction, then you have gynecomastia. Whereas in the women, the balance is actually often in the testosterone direction, and you have breast atrophy. Irregular periods or absence of periods are really quite common.
Yeah. Another question is, Professor Fuhrmann, the COVID-19 infection co-founding factor in diagnosing hepatopulmonary syndrome?
COVID co-infection, HPS, I think basically it's a severe complication. Any patient with chronic diseases, as in patient with cirrhosis for sure, and hypoxemia. I do not have personally an experience with COVID co-infection in a patient with severe hepatopulmonary syndrome. For sure it can occur. At the moment you have to treat it symptomatically. Maybe you can use, if it's mechanically ventilated, corticosteroids, as the British study suggests. I do not have any personal experience. At the moment, there's no specific additional treatment option apart from symptomatic management of severe respiratory impairment and respiratory failure. It's a severe condition, yeah, for sure. Yeah.
So maybe the hepatopulmonary syndrome is the main factor is alveolar shunting. COVID-19 is alveolar discharge. It's the same, some different meaning. It's okay.
If there's some difference, for sure, if you suffer from severe ARDS as a consequence of COVID-19 infection, how it may alter hepatopulmonary syndrome. Severe ARDS remains severe ARDS. In hepatopulmonary syndrome, we have mainly, as you mentioned correctly, intrapulmonary vasodilatation and intrapulmonary shunting. And in my opinion, if you really have a patient with severe respiratory failure, or otherwise, if you have a patient with hepatopulmonary syndrome that requires mechanical ventilation, usually you can oxygenate this patient quite fine. So this is not, if a patient with hepatopulmonary syndrome requires surgery, whatever, you do not have to have too much concerns regarding oxygenation. Usually you can oxygenate this patient very well. If a patient has severe intrinsic lung disease, like COVID-19 infection, for sure this is another leading problem in the acute setting. And I think you have to focus on the management of COVID-19 infection. HBS will not be the deciding disease. It's a chronic disease that's chronic progressive. But if there's acute infection, acute pneumonia, acute COVID-19 infection, there should be the main focus for acute care management in the acute setting at the emergency department, at the normal ward, or at the ICU. And this is the main decision maker in the acute setting.
Yeah, thank you. And Professor Reuben, how sensitive are the method of perfusion of spleen? Should you do them routinely?
How sensitive is finding an enlarged spleen? Is that what you say?
Yeah.
It's really, I don't know any percentage figures, but it's relatively insensitive. Or put it another way, you don't have to have a very large spleen to have hypersplenism. So if you have a patient with hypersplenism with cirrhosis, you can probably be safe in saying that it's due to hypertrophied spleen, because remember, the spleen has to be something like 3 or 5 times larger than normal to palpate it in a given individual. And especially nowadays when there is so much obesity, you may not feel it at all. Even in a patient of normal body habitus, the spleen could still be enlarged 3 times and give hypersplenism because of hypertrophy of splenic pulp without necessarily being palpable. So I think if it's positive, then the answer is correct. If it's negative, you may need to do an ultrasound or some imaging to see that the spleen is enlarged, but you then look for other causes of pancytopenia, antibodies and what have you, and bone marrow and so on, because not palpating the spleen may not be actually a negative finding.
And Professor Reuben, is it routine to do fluid analysis for hepatohydrothorax? The therapeutic time is must to do?
Sorry, I didn't quite catch the question. Hydrothorax is a very common association of ascites because of these little foramina that occur. And so it is not uncommon. In fact, an extreme could be that you have hydrothorax and all the ascites has gone up into the chest. So there has been some, you may have a clinical doubt that this is hepatic hydrothorax, sampling it and analyzing actually will give you the same characteristics of a high SAG and low total protein and so on as you would get in ascites. And of course, the hepatic hydrothorax is also susceptible to the equivalent of SBP, which we call spontaneous bacterial pleuritis. So I think that if you do a chest X-ray or an ultrasound in almost all patients with ascites, you will see a small amount of fluid usually in the right pleural space.
There are cause diseases, many cause diseases such as liver cirrhosis, TB, and urinary heart, and from pancreas. So we must differentiate the.
Oh yes, absolutely. You can't just assume. But in a patient with obvious cirrhosis with nothing else, and you have a hydrothorax, my inclination would be to sample it always to be sure that you're not dealing with occult TB now, and that other things that you mentioned. But nonetheless, probably the most useful measurement you can make is the albumin and the total protein. And knowing the albumin in the patient's serum, you can get a SAG, S-A-A-G, and that will usually clinch the diagnosis against TB and all these other things. But you can't be complacent. It doesn't cost anything to send off the sample for culture and for cytology as well as proteins.
And Professor Ezra, do you use the term MAPLed as an official diagnosis, or still use NAPLed?
Is this question for me?
Interesting question.
No.
It's an area of discussion at the moment in the hepatology community, but I think over the last 2-3 months, most of the liver patient organization and even the patient association recommending the use of MAPLed as more appropriate term instead of the old term of NAPLed. And more importantly, just like few months after the publication of this MAPLed, we have 8 studies so far are showing that the diagnostic criteria of MAPLed are actually more simple, more practical, and it's superior than the old criteria for NAPLed for identifying patients with high metabolic dysfunction, liver fibrosis, and chronic kidney disease. So I guess it seems that from the different perspectives that probably MAPLed will be the more appropriate term to describe fatty liver disease.
And this is Professor Sarin's question. Dear Professor Fuhrmann, excellent talk. How to explain the benefit of new drugs like Valentin? I don't know. What is Valentin?
I think Professor Schein is thinking of macitentan. It's an endothelin receptor antagonist, if I'm right. And this drug is an endothelin receptor antagonist that is used in pulmonary arterial hypertension, and is an endothelin A receptor antagonist. And this can be used for lowering the pulmonary artery pressure, and is one drug that is also assessed, at least in case series, and I think there's a study ongoing in patients with portopulmonary hypertension, and this is a useful tool. Basically, in portopulmonary hypertension, we have the problem that there's a lack of randomized controlled studies. Although portopulmonary hypertension is I think, within the 3 most common causes of pulmonary arterial hypertension. So it is a very frequent finding in the rare disease of pulmonary arterial hypertension, portopulmonary hypertension. But usually most of the studies excluded patients with chronic liver disease. And therefore we have a lack of data in our population with portopulmonary hypertension. But I think macitentan is one useful drug. And there is some experience that it can be also used safely in patients with child A, child B cirrhosis, and child C is frequently a lack of data available.
And of course, this is already the answer. Dear Adrian, Reuben, excellent clinician talk. Any relation of spiders with the peripheral vasodilation and the endocrine dysfunction with the HPG? So no. Professor Reuben's answer is no connection between spiders and the HPG.
No.
Yeah.
Can I ask a question to Dr. Fuhrmann, one of our studies about 10, 12 years ago, we found that patients who have got hepatopulmonary syndrome, when they are lying, it is mild or subclinical, not severe. When they are lying, the PO2 levels are low, but when they stand up, their saturation and their oxygenation improves. So we always thought that standing will recruit more of alveoli and more of the lung. So the question is, do you think that is also possible? Because once the disease becomes severe, then these patients also behave in a similar manner or not. So first, is there a lung reserve which is compromised in advanced disease, and how do you assess the lung reserve?
It's a very interesting and also challenging question. As you mentioned, there's a well-known phenomenon that the terms platypnea and orthodeoxia. That means that the dyspnea is worsening in the upright position. And I think one of the main contributing factors is the increased interpulmonary shunting that is clinically more advanced present in an upright position than in the lying position. And the increased shunting and the decreased oxygenation in the upper levels of the lung may contribute to this increase of dyspnea in patients with hepatopulmonary syndrome in the upright position. I think it's a useful tool to assess this alteration in patients with hepatopulmonary syndrome, with advanced hepatopulmonary syndrome. It's a well-described phenomenon. Regarding the clinical consequence, being honest, I'm not sure. I think the main causes of dystalactasis, as you mentioned, in patients with chronic liver disease, mainly ascites, are mainly pleural effusion. If the degree of, I do not think in hepatopulmonary syndrome, this orthodeoxia and platypnea are not a consequence of reduced ventilation, but it's a consequence of increased perfusion of several areas of the lung that contribute to this phenomenon, but not a reduced ventilation. It's an increased perfusion of several regions that do not occur in healthy persons.
And Professor Gani, could you comment, please? Yeah, again, I noted Professor Reuben's email address is Adrian Reuben 789@gmail.com. Is that right?
You have to spell Reuben R-E-U-B-E-N. There are many variations, but the best one is my one.
Just to put, some people know that Adrian is amongst the most learned Shakespeare of hepatology. You have to read what he writes, and he was one who was always writing in hepatology, a column for almost 10 years or so. And therefore, I encourage everyone to read his columns of late 90s and maybe 2000 onwards. And he has a rare sense of humor and depth of knowledge. And the combination makes Adrian a beloved teacher, a master clinician. And
well, that's nice. I prefer money to flattery, but never mind. Let me point out to the members of the audience that there is a new series of articles, essays on the history of hepatology, published online now in the AASLD journal Clinical Liver Disease. Now, I'm not the author, although I'm the editor, and I contribute quite strongly to these articles, but they're really wonderful. within the new year, Professor Sarin promised me an essay as well, and I'm looking forward to that. So far, we've had 17 published on all aspects of the history of hepatology. 3 more are with the publisher now, and I have another 15 to edit. And by the end of, I think, next year, we will have published probably around about 50 essays on the history of our field. So I strongly encourage people, and if they can't access this journal and they email me, I would gladly send them PDFs of the published articles. There's 17 already published, and there are more to come. So I wouldn't advertise my old essays on hepatology from 10 years ago, but I would advertise these new ones. I think they'll give people a lot of pleasure because they're amusing and enjoyable, but also very informative.
Okay, I'd like to closing remarks. Thanks to Professor Reuben and Professor Eslam and Professor Fuhrmann for today's informative lecture. And I hope today's lecture will help our patient management and our research field. Thank you all. Bye.
Pleasure.
Thank you for all the speakers.
Thank you for inviting me. Very nice.
Thank you. We'll go back to the Izumi.
Thank you very much, professors. So now it's the end of the program. We appreciate your participation and great support. Thank you very much.